Thanks again for attending our mini med school series. So today we'll be looking into a variety of common medications that older adults may use, and also seeing if there's any potential interactions that may occur there. And hopefully you'll be able to learn something and increase your ability to use your medications safely. So we'll start off with a territorial acknowledgement as always. So I'd like to begin by acknowledging that I'm personally joining you from the unceded territory of the Coast Salish peoples, including the territories of Musqueam, Squamish, and Tsleil-Waututh nations. And I'd also like to acknowledge that most of you are joining me from the island. So I'd like to acknowledge the Lekwungen peoples, on whose traditional territory the University of Victoria stands, and the Songhees, Esquimalt, and Wasanich peoples, whose historical relationships with the land continue to this day. And the usual disclosure statement. So I am a medical student, so please don't go changing any of your medications after you hear this talk. And these don't substitute or constitute medical advice. And there are several different types of drug interactions that can occur, and it would obviously be impossible to include every one of them here. But I have tried to include some of the more frequent ones or ones that many people may not be aware about. And it's always a good idea before you start a new medication or change a medication to double check that there's no drug interactions with your existing medications, and your healthcare providers, especially your pharmacist or your main healthcare providers, are your best resource for these types of questions as well. So here's a broad outline for what we're going to be covering today. So we have two kind of big overarching classes of interactions. So the first one is pharmacodynamic, and I'll talk about commonly combined medications that can either have an additive effect, meaning they're doing the same thing, or an antagonistic effect, meaning that they're potentially doing the opposite and canceling each other out. We'll also talk about some pharmacokinetic interactions, which includes topics such as absorption, distribution, metabolism, and excretion. So the way that medications may alter how these different processes occur. And it'll also bring up some drug food and drug disease interactions that may potentially occur. And like I said, this won't be an exhaustive lecture by any means, and I'll give you some resources of where you can look up to see if any of your medications do potentially interact, and something that you could potentially use in the future as well. So we'll start off with a quick poll question here. So true or false, when my doctor asks which medications I'm on, they only really want to know my prescription medications. So you should see a poll in front of your screen. And this is a bit of a leading question. Okay, so it looks like everyone answered correctly. So the answer is false. They definitely want to know beyond the prescription medications, even if they don't necessarily explicitly say that. And hopefully this talk will show you exactly how this could be a potential issue. And just a reminder, if you want to get rid of that poll, you just have to exit out in the corner of the screen. So everyone got it right, which is great. So we'll talk about additive interactions first. So if you take two or more medications that have similar biological properties or active ingredients and have similar end effects, this could lead to an overall heightened effect with more serious side effects, which obviously, if it's unintentional or unknown, could lead to a pretty serious situation. So some simple examples that people may not be aware of are with cold and flu medications. So for example, acetaminophen, which is often branded as Tylenol, is commonly used for fever, and a lot of people use this medication. But it's also added into several other over-the-counter cold medications that are not explicitly labeled as such. So for example, NyQuil, obviously the font is pretty small here, but the big label that you see here is NyQuil, but underneath you'll see acetaminophen is added. And because many people just refer to Tylenol as Tylenol, they might not actually realize that they're taking two of the same active ingredients. And so this could lead to quite a high dose depending on how much you're taking. And again, many cold and flu medications will explicitly say not to give to anyone under the age of 6 as well, because this has ended up being a really big issue in that age group and led to a lot of ER visits. So this also highlights the importance of reading the fine print on over-the-counter medications and double checking the active ingredients that are in your medications to make sure that you're not duplicating them at all. Another common example are NSAIDs, or non-steroidal anti-inflammatories. So this includes medications such as ibuprofen or naproxen, and they're typically used for things like pain relief and inflammation. So as you will come to see, despite them being over the counter, they can interact with a lot of things. And typically, potentially from an additive point of view, but also from an antagonistic point of view. So when combined with certain antidepressants, so with prescription medications, so things such as selective serotonin inhibitors, so this includes medications such as citalopram or fluoxetine or sertraline, there's a really long list of them. But also with other classes of medications such as glucocorticoids, such as prednisone, this can lead to an increased risk of bleeding because SSRIs in particular prevent proper platelet function, meaning that they can't, that they reduce the ability for platelets to clump together and form a clot. And this is also a characteristic of NSAIDs. So when you add those two effects together, you can unfortunately increase your risk of bleeding. And NSAIDs in general are unfortunately known for causing potential gastric ulcers with prolonged use as well. So that could potentially be a really big issue. When combined with aspirin, so on the antagonistic side, this can lead to an issue with the prevention of cardiac events in coronary heart disease patients. So unlike other NSAIDs, aspirin prevents platelets from clumping for a longer period of time. So hence, this is why aspirin is typically the go-to for preventing things like heart attacks in people who are high risk. So essentially, NSAIDs can get in the way of that and prevent those longer-term benefits, on top of the fact that both of these medications are NSAIDs, and you'd also get an increased risk of things like gastric ulcers as well. Another common example are ACE inhibitors, and these are used for hypertension, cardiovascular disease, a whole bunch of stuff. And these are medications that end in the ending pril, so ramipril, perindopril, lisinopril. There's a very long list as well. One of the more serious side effects of ACE inhibitors is that they can cause hyperkalemia, or too much potassium. And that's just on their own. That's an issue that they can cause. Potassium-sparing diuretics are another type of medication that can be used in hypertension and cardiac disease, and this includes medications such as spironolactone or amiloride. And so but essentially both of these medications can potentially elevate potassium on their own, and if you combine the two, now you can start to get really, really high potassium. So that can be a really potentially big issue in terms of causing cardiac arrhythmias, and can potentially be fatal if the levels get high enough. But that being said, it should be noted that most of the time, especially when you're starting these medications, your electrolytes will be monitored for that specific reason, and it's not going to get super high super quickly, but just something to note. On the flip side, so for antagonistic reactions, ACE inhibitors combined with NSAIDs, another NSAID interaction, can potentially cause some issues with reduced effects and risks of acute kidney injury in certain situations. I'll show you how that happens on this slide. So it can be an unfortunately pretty common interaction and can potentially have some pretty serious long-term side effects. So on top of ACE inhibitors, angiotensin II receptor blockers, which is another hypertension medication, can also cause this interaction when combined with NSAIDs. So what you're looking at here essentially is the nephron, and this is an area in the kidney where blood is essentially filtered, and there are thousands of these. So essentially what happens when you combine NSAIDs and these hypertension medications is that it will reduce blood flow through the kidney. If that pressure becomes low enough, this can potentially cause an acute kidney injury, which is a medical emergency. Now, again, normally really isn't an issue. If it was, then these medications would never have been on the market to begin with, because this type of interaction would occur so frequently. But the real issue that I want to point out here is that if you're sick and potentially very dehydrated, so you're not getting enough fluids, or potentially you're having a lot of vomiting or diarrhea or things like that, there's going to be less volume in your blood to begin with. And this is going to reduce the pressures going in even more due to the reduced volume. So as a result, substances can build up in the body since the kidneys aren't filtering anything, and this can severely injure the kidneys. So oftentimes, this is why patients are told to plan for sick days, which typically result in you abstaining from your hypertension medications when you're sick and potentially dehydrated, since chances are you being dehydrated will actually lower your blood pressure. So just to summarize, basically what happens is that the hypertension medications dilate what's going out of the glomerulus here, and NSAIDs vasoconstrict, and this really reduces the pressure going in and out. Another medication interaction that I wanted to talk about, another additive interaction that I wanted to talk about is serotonin syndrome. And this is a pretty rare thing, but it can be quite serious. This occurs when you add 2 or more medications that lead to elevations in serotonin, which is a hormone responsible for mood and several other functions. And typically these can, if this is to occur, it will occur when you're starting a new medication or increasing a dose. But like I said, this is typically a pretty rare side effect, but one that can be quite serious and even life-threatening. So some examples of medications that increase serotonin are antidepressants. So I've already mentioned selective serotonin reuptake inhibitors. There's also selective norepinephrine reuptake inhibitors. And there's a big long list of those, as well as bupropion, which can help people stop smoking. There's also anti-migraine medications, certain anti-nausea medications, such as ondansetron or Zofran, as well as certain herbal supplements and opioids as well. So any symptoms that result from this, so it can range from mild. So mild symptoms would be like agitation, insomnia, confusion, shivering, or it can range to becoming more severe depending on how much serotonin is accumulating. So more severe symptoms would be like fever, tremor, seizures, irregular heartbeats, and if undetected can potentially be fatal if left untreated, especially with issues around the seizures and irregular heartbeats. Now, usually just stopping the medications will resolve this problem, but just something to be aware of there. So this is a table of some other common additive or antagonistic reactions and some of the consequences that can result. So we already talked about the NSAIDs, increasing the risk of gastric bleeding over here, as well as the risk of high potassium or hyperkalemia when you add ACE inhibitors and spironolactone. And we mentioned serotonin syndrome, so triptans are just anti-migraine medications. And then you add some other ones as well, so reduced effects or potential issues with the heart as well. So we'll move into our discussion about drug metabolism. So there are 4 main giant different categories to do with drug metabolism. So absorption, distribution, metabolism, and excretion. And we'll break them down one by one to see where potential interactions can occur in these areas. But before I do that, I just wanted to kind of summarize what happens to an oral medication and where some potential modifiers can be along the way. So the majority of medications are ingested by mouth. This is typically the easiest, but also cheapest way of taking medications. And between the mouth and the target site of the medication, there are many different ways where it can be modified, and this will help dictate the efficacy of the medication or potentially the toxicity within the body. So after the mouth, it travels to the stomach, where the acidity and other substances that are present there, such as other medications, can have an effect on how a drug is transformed. Then it passes into the small intestine, where the majority of the drugs are absorbed. And so in the small intestine, there are a group of transporters called Pglycoproteins, which I will explain a little bit later. And this can dictate how much drug will enter the blood versus stay in the intestines and move into the feces. If it has been absorbed from the small intestine, it will enter the blood and head to the liver, because that's exactly where it drains. So you may have heard of the term first pass metabolism. So this is when a drug will be metabolized at the liver, often to concentrations much lower than was ingested. And once the drug has been metabolized, it's essentially been transformed into something completely different and usually is inactive at that point. So this is a big reason why oral medications are often given in much larger doses than, for example, intravenous medications, since they know that there will be a significant concentration that is lost at that point. And so you need to compensate for that by giving more medication. You may have also heard of the concept of bioavailability. So the fraction of drug that passes and remains active after the liver is referred to as the bioavailability. Some medications, this can be quite high, such as 80 to 90%. Some it can be as low as 2%. And then several enzymes in the liver as well are going to dictate how much a medication is metabolized, and other medications or potentially diseases can alter this as well. And we'll go over some examples of those. So again, I really liked this photo as a great illustrator of how much drug concentrations can be decreased as they pass through different organs when they're taken orally. So as you can see here, you have 100% of the dose that you ingested when it goes into the stomach, but by the time it makes its way through the small intestine, you've kind of lost quite a bit here and you're down to 70%. And then once you go through the liver with all these enzymes in there, you only will potentially be left with 15% or whatever percentage it is, depending on the drug itself. So after the liver, the medications will move to the bloodstream and travel to their sites of action. And so there are always a certain amount of proteins in the blood called plasma proteins, and albumin is the most common one. So these proteins can have the potential to bind medications as well. And when they are bound, typically that means that they become inactive, often because they're quite big with the protein and they can't diffuse into the organs. The rest that remain unbound will travel to the organs to exert their desired effect. Now, once the drug has become used or becomes inactive, either by the liver once it goes around again or transformation somewhere else, it can be removed via the kidneys and then into the urine, or the liver can re-excrete it into the bile, which is stored in the gallbladder and then released into the small intestine, which will eventually be excreted into the feces. So it should be noted, though, medications that are given intravenously, intramuscularly, sublingually, like under the tongue or rectally, will essentially skip the last slide that I mentioned and go straight to this slide. So they skip the first pass metabolism, they skip the liver, and so that's why often the doses are much smaller, but they can also sometimes be a bit more effective because more of the drug will reach the target organ at the end. Okay, so hopefully that gives you a little bit of a better idea of how a drug passes through the body. So we'll get into now how the drugs are metabolized. So like I said, there's 4 major processes that occur in order for a drug to be metabolized. Absorption is the first step and occurs mainly through the digestive tract for oral medications, like I mentioned. So again, most medications are not 100% absorbed, and therefore an increased dosage is often given to compensate for that. And so this is what, and again, this isn't an issue if you're giving medications intravenously, since you're going straight to the bloodstream. Another important factor that I'll mention in a little bit is how stomach pH can affect absorption, as well as there are certain medications can increase or reduce the bioavailability of other medications through the modification of Pglycoproteins, which I'll explain a little bit as well. That leads us to our next poll, which is true or false, Tums and other antacids are harmless. I'll just give it a few more seconds. Okay. Good, the majority of you, or everyone got it right. So the answer is false. Tums and other antacids definitely are not harmless, and I'll explain to you why that is. So antacid medications are really important to be aware of when it comes to interfering with absorption. So as I've mentioned many times already, when you ingest an oral medication, it goes down to the stomach, then the small intestine to be absorbed, then to the liver. And so I've used Tums as the primary example since it's usually the most common, but other antacids such as milk of magnesia, which is magnesium hydroxide, or Alka-Seltzer can also have the same effect. As well, prescription medications like proton pump inhibitors such as omeprazole or pantoprazole or other medications that reduce stomach acid can also have similar effects. And the big issue with Tums and these antacids has to do with changing the acid concentration in the stomach. So as we all know, the stomach is a very naturally acidic environment, especially compared to the blood. And so most oral medications are designed with this in mind in order to withstand the stomach acid. Often medications will actually even have a protective coating on the outside, which helps them withstand the stomach as well. So if the pH of the stomach changes, and typically with these antacids, it'll become less acidic or more basic, this can change the way that medications are modified in the stomach and can either increase or decrease their strength. Given, and in the specific relationship with Tums or calcium carbonate, calcium and carbonate can also separate in the stomach, and they are capable of binding to certain drugs and making them less effective as well. And this is particularly an issue with certain antibiotics, levothyroxine, which is for thyroid, low thyroid, bisphosphonates, which is for osteoporosis, as well as iron supplements. So often these medications will be, you'll be told to take them without food in order to increase their absorption. So overall, a recommendation with Tums, although it seems that this group knows that these aren't harmless, it's recommended to take them only as needed. And if you do happen to need to take them, wait at least 2 hours before or after taking other medications in order to maximize the effectiveness of all of them. So this is a little bit of a busy slide, and the language here is a little bit naturally confusing, so I'll try to make it as clear as possible. But another way absorption can be modified is through the modification of Pglycoproteins. And Pglycoproteins are transporters in the gut that control how much drug is absorbed. And so that essentially they're responsible for moving medications back into the GI tract to prevent them from being absorbed. So essentially they're acting like a shield, preventing medications from moving into the blood. So essentially anything that induces Pglycoproteins will increase the activity of the transporter and decrease the absorption of the drug. And this will reduce the effectiveness of it because less drug is going to get into the blood and to the target organs. On the other hand, inhibitors will do the exact opposite. And so they'll decrease the transporter and increase the absorption of the drug, which especially in drugs that have a narrow therapeutic window where small changes in concentration could be an issue, this could lead to either high or toxic levels of a medication or could potentially make it less active. And this could potentially have a big issue if you're talking about systemic antibiotics, for example. So some really common ones that I wanted to point out here were calcium channel blockers. So I know a lot of people are taking these. So these can be inhibitors and they can increase the absorption of other drugs, as well as some antibiotics and antiarrhythmic drugs as well are quite common. And this is just another picture to hopefully help illustrate that inducers will increase the activity of Pglycoproteins, whereas inhibitors will do the opposite and lead to more drug being absorbed. It's also a really interesting fact that Pglycoproteins are actually found on many other cells around the body. And this is a prime resistance mechanism of tumors, for example. And this is how a lot of them become resistant to things like chemotherapy medications, because they become really good at pumping medications out of the tumors, and that prevents the death of tumor cells. And unfortunately, we haven't really found good ways of getting around this yet, but it's certainly an area of research interest that's being explored currently and might be coming up a little bit in the future. So you might have seen the little star by St. Johnswort on that other table, and I wanted to quickly mention this as well, as it can be a really common offender in drug interactions. And so essentially St. Johnswort originates from this 5-petal yellow flower here, and has apparently been used since the beginning of time. So in the past, it was apparently very helpful for preventing demonic possession and evil spirits. But nowadays it has been claimed to help with mood as an antidepressant, and also potentially possess anti-inflammatory or wound healing properties. The only big problem here is that, as with many supplements, is that the effects have only really been either shown in animal studies or in very small studies. And this means that there's really limited evidence in humans. And unfortunately, what became really clear in a lot of these small studies was that there are several medication interactions with St. Johnswort. So there were some case reports even of St. Johnswort causing complete treatment failure, which one of the examples they had used was with someone who had an organ transplant, and St. Johnswort completely deactivated their immunosuppressants, and unfortunately they went into rejection for the organ. So it can be quite potent, and so it really interacts with medications such as Warfarin, which is a blood thinner, which obviously that could have some pretty serious consequences as well. I already mentioned immunosuppressants, so things for cancer, transplants, as well as antifungals. So these can have some pretty serious consequences. That being said, it doesn't mean that despite the limited evidence, that doesn't mean that St. Johnswort doesn't work. There were some studies that have shown benefit over placebo, especially as an antidepressant, but others also haven't. And especially from a medical point of view, it's often very difficult to make recommendations based on very few studies that have mixed results. And so typically it won't be recommended as a treatment. But again, this provides a really key example about how important it is to talk with your doctor before taking any type of supplement or herbal medication or remedy, because there can be quite a bit of harm in taking these, and it's important to make sure you mention these if you're ever asked what medications you're on as well. We'll move into drug distribution now. And so this is how the drug will leave the blood and reach the tissues and be distributed. This isn't a very big area where interactions can occur, but it is important to know that the blood flow and perfusion of tissues can affect how much drug is delivered to that area. So another issue is with protein binding, and that's an important factor. So you may recall that I mentioned that proteins within the blood can bind drugs and essentially deactivate them. And so if you potentially have a condition that elevates the proteins in the blood, such as pregnancy or certain diseases, this may affect how much drug is available and could potentially affect the amount of drug that is bound to protein and therefore is inactive. Or there are certain diseases that can cause fluid or volume overload, such as severe heart failure, end-stage liver or kidney disease as well, which would increase the amount of fluid in the tissues and dilute the amount of drug that is being given. So typically dose adjustments will be made in those cases. So metabolism is how the drug is transformed in order to be excreted or gotten rid of. So this mainly occurs in the liver. And so this is the biggest area for potential interactions that can occur. And so there are two phases of drug metabolism in the liver. The first are conducted by a group of enzymes called cytochrome P450 enzymes. And these enzymes are primarily responsible for transforming drugs into more soluble forms so that they can later be excreted. And so these enzymes can be induced or inhibited by various drugs, foods, diseases, and I'll mention a few coming up. And it's also a very big area for potential interactions. So essentially, if similar to the Pglycoproteins, if anything is inducing these P450 enzymes, this will mean the body will process drugs faster, and this will decrease their effectiveness. Alternatively, if they inhibit these enzymes, the drug will stay in the body for longer, and this can be potentially toxic. Overall, the second phase is done by non-P450 enzymes, and it essentially just ensures the end product is ready for excretion or deactivates the drug entirely. But the phase 1 is typically where the interactions do occur. It should be noted, though, that some medications are exclusively or partially metabolized by the kidneys as well, although liver metabolism is most common. And as I've mentioned before, any medications that are not given orally, so given through IV or sublingually or rectally or intramuscularly, will essentially skip the liver on the first go and go straight to the blood, which is why they can be more effective and are often used in situations where maximal efficacy is super important. So in situations where people are very sick or septic, for example, this is why IV is obviously the go-to. So essentially, this is just another summary table here, and don't worry about the number of the enzymes, but I just wanted to highlight some important examples that may be involved with more common medications. So again, antibiotics interact with a lot of different medications, and so they're typically on here as inhibitors, as well as some of those antidepressants that we were talking about, as well as proton pump inhibitors as well. And by no means is this exhaustive. There are lots and lots of different medications that can interact. And as well, St. Johnswort makes another appearance right there. So as I was saying, liver is a very key area for drug metabolism. So many drugs rely on the liver's ability to transform the drug in order to not be released into the bloodstream at toxic levels. So if there are issues in the liver's ability to do so, there may be some consequences, especially if there's severe liver disease. So similarly, the effects of many drugs are also dictated by the degree to which they bind to proteins in the plasma, like I've mentioned. And so with severe liver disease, certain plasma proteins, notably albumin, will be reduced in the blood because the liver won't be able to produce as many. And so this will leave more free drug in the blood, which can potentially lead to toxic levels. And as well, liver disease in its more advanced stages, so cirrhosis essentially has the potential to affect drug metabolism and excretion. And there are a variety of different reasons for why this is the case, but it appears that advanced liver disease may decrease certain drug metabolizing enzymes. And there can also be downstream effects with drug excretion into the bile as well as the kidneys. And so typically you'll be prescribed less drug if you have severe liver disease because there's the risk of drug accumulation due to slower metabolism. So excretion is the final process in drug metabolism and commonly occurs at the kidneys and through the urine, but it can also occur through bile and through the feces. So any potential disease that impact the ability of the kidneys to filter may impact the body's ability of excreting a drug. And we'll talk about kidney disease a little bit more. So similar to liver disease, acute or chronic kidney disease has the potential to decrease the amount of drug that is excreted into the urine and out of the body. And so, like I mentioned, there are some drugs that are almost exclusively dependent on kidney metabolism and not on the liver. And so obviously these drugs are especially affected and typically will be avoided in the setting of severe kidney disease. But there's also evidence that there are changes in the way drugs are cleared at the liver, even with just having kidney disease, as well as more changes in protein binding. So that leads to more free drug in circulation, as well as altering the volume of distribution. And typically this will be due to fluid accumulation. So as a result, this is another reason why dialysis is needed in end-stage kidney disease. Otherwise, drugs can't be cleared out of the blood at all. And it often will be recommended to modify dosing of medications if you're in this category as well. And you'll typically have reduced doses as well. Okay, so that leads us to our first or our only intermission. So if you have any questions, you're welcome to put them into the chat and then I'll address them when we get back. But we can just take a quick 10-minute break. So we'll meet back at 1:50. So the last part of our talk, we'll be talking about potential interactions with food or drinks, as well as potentially some diseases as well. So our first one is grapefruit juice. So a pertinent food-drug interaction is between grapefruits or grapefruit juice and certain medications. And so there have been multiple studies that have shown that it does have the potential to block the CYP3A4 enzyme in the liver, which, as we've discussed, can potentially cause drug accumulation and more side effects or toxicity. But just so you know, this hasn't been found to be an issue with orange juice, despite them being in the same family. So just something to be aware of. And this is actually particularly true for some very common medications. So certain statins, such as simvastatin or atorvastatin, certain calcium channel blockers, such as nifedipine, and immunosuppressants, such as cyclosporin. So there's multiple other ones as well, but those are definitely some of the more common ones. And so it would be recommended to avoid grapefruit juice if you're on those medications. So many people forget that alcohol is actually a drug and is certainly one of the most commonly used ones. And its main action is to depress the central nervous system. And it interacts with almost every drug. So it can magnify certain pre-existing side effects, such as drowsiness, which can obviously become potentially hazardous if you're taking alcohol and these medications together and operating things like a car or heavy machinery. But obviously, hopefully you're avoiding drinking alcohol and doing that at the same time. And it's also known to affect liver enzymes. And so a primary example of this is with Tylenol, where it can competitively inhibit the same enzyme that's needed to metabolize Tylenol, which can lower the amount of Tylenol that you need to take in order for it to become toxic. And this is essentially true with chronic alcohol use and potentially resulting liver damage, which can become potentially fatal. So for example, the usual toxic dose of Tylenol is around 6 to 7 grams. So you taking that much all at once, whereas with chronic liver damage, it can be closer to 2 to 3 grams or 3 or 4 extra strength tablets. So it does lower the threshold quite a bit. Warfarin is an anticoagulant or blood thinner that is used to prevent blood clots. So I have talked about warfarin quite a bit in my other talks, but warfarin in particular has a lot of potential drug-drug interactions, especially when compared to the newer anticoagulants, which is often why those are preferred over warfarin. But aside from that, warfarin also has the potential to interact with food. And so warfarin works by inhibiting an enzyme called vitamin K reductase. And this prevents certain factors in the clotting cascade from forming. And this prevents a clot from forming. If you consume vitamin K, which is present in certain foods, this has the potential to decrease the effects of warfarin. So and put you at risk for blood clots. So basically you're just canceling out the effects of warfarin. Vitamin K is naturally found in certain foods, so namely green leafy vegetables such as kale, spinach, lettuce, as well as other vegetables such as Brussels sprouts and broccoli, and a couple other things as well. So typically it's recommended to decrease the consumption of those foods when you're on warfarin to avoid this effect. It also highlights the importance to be aware of multivitamins if you're taking a multivitamin, and this goes for any medication. So warfarin in particular, there are some multivitamins that do include vitamin K, which obviously is an issue if you're on warfarin. So it's always really important to double check the label of the multivitamins that you're taking, just to make sure that you're not potentially adding something like vitamin K when you're taking warfarin, or for other medications as well. Another odd but important example to be aware of is black licorice. So the FDA apparently issues a warning prior to Halloween every year that if you're over the age of 40, eating 2 ounces of black licorice a day for at least 2 weeks could lead to an arrhythmia or a weird heart rhythm. So it contains an active ingredient called glycyrrhizine, which can cause low potassium or hypokalemia. And low potassium can be life-threatening and can lead to abnormal heart rhythms or arrhythmias, hypertension, swelling, lethargy, and potentially congestive heart failure. So it is recommended to avoid, for anyone, taking licorice in large quantities, especially if you are taking medications that can lower potassium as a side effect. So this includes things like diuretics, for example, which include common blood pressure medications such as hydrochlorothiazide. So if you're a really big fan of black licorice, potentially you might want to cut back on that habit if you happen to be on these lower potassium medications. Speaking of potassium, as we all know, potassium is in the food we consume every day. And normally it's never a problem, but if you do have certain medical conditions or take certain medications, it can be an issue. So elevated potassium or hyperkalemia can be a side effect of many common medications. And if potassium levels get too high, this can push us over the edge. And again, it's not likely to happen from taking one banana or eating one apricot, but essentially, especially if you're on multiple medications that potentially elevate potassium, such as the hypertension medications listed here, or potentially anti-inflammatories or immunosuppressants, it's important that your electrolytes be checked to ensure that they're not too high. And if it is, they'll typically recommend to avoid certain high potassium foods such as bananas, dried fruit like apricots or beans and lentils, potatoes, things like that. And this news cutout is a potential example of what can potentially happen if you're drinking a lot of tea every day. And I certainly hope that none of you are drinking pitchers of tea with 100, 150 tea bags per day. But this example highlights that more is obviously not always better. And this leads us to our last food interaction, which is green tea. So although green tea is often touted for its many potential health benefits, you might be surprised to know that it's also a potential contributor to drug interactions. So some of these have to do with the caffeine content and are relatively mild. So basically, some medications may slow down how fast caffeine is broken down, and therefore you might feel a bit more anxious or jittery. So nothing too serious. But it could lead to potentially more serious side effects. So for example, if you have a cardiac arrhythmia or are at risk for one and you ingest some green tea, the caffeine can increase your heart rate, and this can potentially lead to the development of an arrhythmia. So most of the drug interactions are listed, that I was looking at, are listed at either moderate or minor, meaning that they may interact. Therefore, you should kind of be cautious with this combination. But I thought I'd highlight some that were a bit more, that might apply to this group a little bit more. And something I also want to note is that the terms green tea and green tea extract were kind of used interchangeably. And green tea extract is more of a supplement. So it's a much higher concentration of green tea, and it's not the type of tea you drink. But that being said, a lot of them did mention green tea as well. So things like atorvastatin or Lipitor, as well as it's recommended to abstain from green tea with any medications that affect clotting. So things like warfarin, clopidogrel, or aspirin, as well as chemotherapy drugs. So as with literally any medication, it's always a good idea to double check this with your doctor or pharmacist. And often they'll explicitly tell you if you shouldn't be consuming green tea. But green tea extract in particular has a much higher risk of potential interactions. So it's important to be careful with that one. So you might be wondering, well, if green tea interacts with things, does black tea as well? And so the answer is less so than green tea. And majority of the interactions that I did see were due to the same issues with caffeine as green tea. But that being said, I'm not sure if a black tea extract exists. And so this might also be why, since, like I said, the majority of the issues seem to have to do with green tea extract. But the tannins that are contained in black tea may also reduce absorption of medications as well. So oftentimes there's certain supplements, such as iron, you're recommended to not consume tea within 2 hours of taking the supplement. And we'll just wrap up with drug disease interactions here. And so this interaction doesn't happen frequently because it's pretty well known, but presents a good example of how two medications can potentially cancel each other out, or a condition and a medication. So beta blockers are a medication group that end in lol, so it includes labetalol and metoprolol, and they're used in a variety of common cardiac conditions and to reduce blood pressure as well. And their mechanism of action is related to blocking of the beta receptors. And this allows them to exert their desired effect, which includes decreasing heart rate, contractility, and lowering blood pressure. Asthma, on the other hand, is an inflammatory disease of the airways. And so the primary medication for asthma are called bronchodilators. And this includes things like salbutamol in the puffer format. And so the medication in puffers aims to bind to the beta receptors in order to relax the airways and decrease inflammation. So if you can imagine taking beta blockers, which block that receptor in the setting of asthma, where the medication wants to bind to those receptors, you can now have a medication that may potentially worsen asthma by causing the opposite effect on the beta receptors that you would want. So essentially you're causing constriction of the airways rather than trying to dilate them. And that would worsen asthma. So as a result, beta blockers are usually contraindicated in the setting of asthma, but it just provides a really good example of how a medication could worsen a condition. And this is our last example here is another important example of how important it is to disclose over-the-counter medications. So there have been significant drug disease interactions between nasal decongestants and cardiovascular disease. So nasal decongestants work by stimulating alpha adrenergic receptors in the blood vessels of the nasal mucosa. This causes them to constrict or narrow, and this helps relieve the symptoms of congestion. Now, although the actions are primarily local, meaning that they mainly work on the nasal mucosa and don't spread, there is the potential that they can spread throughout the body and produce systemic effects. So if you think of issues that pertain to cardiovascular disease, so namely that typically the heart is struggling to work as well with heart failure, or the vessels of the heart are narrowed in coronary artery disease, you can probably reason why a medication that causes narrowing of arteries could potentially pose an issue in those situations. They can also raise blood pressure, and again, by causing that vasoconstriction. So overall, things like nasal decongestants can really worsen or potentially cause a really big issue with coronary cardiovascular disease. So I have one last poll for us. And so it's saying true or false. There's a website that my doctor can check which medications I'm on, so it's okay if I forget to mention some. Give it a few more seconds. All right, so much more mixed results on this one. So the answer is it depends, and I'll explain a little bit more about that. So Pharmanet, so it is true that there is a website that your doctors can go to check which medications you're on, and it's called Pharmanet, and pharmacists can access it as well. But I think there are a lot of misconceptions on how it works and how well it works as well. And so they can access your medication records, so they can see what dose you're on, how long you've been on it, and why you're taking it. And so I wanted to highlight this because I think many people assume that doctors and pharmacists automatically know what medications they're on. And unfortunately, this isn't always the case. And this also really emphasizes how important it is to know what medications you're on so that you can share this information as well. So there are many caveats of Pharmanet, mainly that it won't necessarily include everything. So some pertinent examples are that over-the-counter medications, unless they are prescribed, won't be on there. Supplements, vitamins, herbal remedies won't be on there as well. Medications that you may have received as a sample from the doctor, you won't be on there as well. Prescriptions that have been written but haven't been filled. Any prescriptions filled outside BC will not be on there. And certain medications dispensed by certain agencies, so BC Cancer is a notable one, may not be on there as well. And so my last slide here is just hopefully a big takeaway from things that you may have learned in this talk. And like I've said, medication interactions are extremely common and for the most part are quite preventable with proper patient education. And given the current strain, as we all know, on our healthcare system, it can be all too easy for these messages to not be given to patients. And hopefully these tips can help you take a bit more of an active role in your care. So my tips include making a list of your medications and taking it with you to appointments, and including the name, the dose, and how often you take it and why you take it. An example of this, I had a volunteer patient in our clinical skills session who did this, and it was really helpful for both of us to be clear on which medications he was on. And it also helped avoid the I'm on the blue and yellow pill conversation, which can make it really hard to figure out what you're actually on. And this also decreases the chance that you'll forget to mention a medication as well. So it helps reduce stress on both ends and makes it really easy for us as well. Number 2, stick to one pharmacy if you can. This helps with continuity and can help you develop a relationship with your pharmacy or your pharmacist. Often it is the pharmacists that will catch potential interactions when they're writing out your prescription. And so if you're getting your prescriptions in one place, this helps reduce the chance that something will be missed. Number 3, inform your provider of any new medication, supplement, vitamin, herbal remedy that you're taking, especially if you're seeing multiple different doctors for multiple different reasons, or you're using walk-in clinics because you don't have access to a family doctor. Your primary care provider may not be aware that a new medication was added on. And so supplements, vitamins, and herbal remedies are also very important to mention, as we've seen, as these can also cause interactions as well. And I think most people make the mistake of not thinking that these are medications, and doctors have a bad habit of not explicitly asking either. So it can be very helpful to just volunteer that information up front. Number 4, over-the-counter medications do count as a medication. So as we've seen, things like ibuprofen, Tylenol, allergy medications, antiacids do have the potential to interact. And I think many people make the mistake thinking that there are no consequences to over-the-counter medications. But as you've hopefully learned, there can be, and these might actually be quite relevant. And even if you don't take them super often or take them here and there, it's important to mention that you do take those, as there can be some serious consequences. Number 5, and this is just more of a practical one, make sure that your medications are properly labeled and in the correct containers. And it can be super tempting, especially when you're traveling, to just put them all in one box. But many meds do have the habit of looking the same, and it can be hard to keep track of which ones you've taken throughout the day. And so daily pill containers can be very helpful for this and ensure that you're actually taking your medication at the time that you should be taking it. And if you are having trouble remembering time and dosage, or you just don't feel like putting them into the pill containers, you can ask the pharmacy to do this for you. And they put them in bubble wrapping, which will say which medications you're on, what time, and they'll put them in different boxes based on the time of day and the days that you're supposed to take them. And this can really help reduce the burden on you. Number 6, just make sure that when you are given a new medication, I know they give you a big, long list of things that you should read. It really is important to read those medication inserts because a lot of this information is included in there. And that will typically explain all of the questions about dosing and what time of day you should be taking it and whether you can or cannot take it with food, as well as pertinent interactions as well. Number 7, if you're having trouble taking oral medications due to the size of them or swallowing difficulties, mention this to your doctor or pharmacist as they might be actually able to find an alternative. So it can be easy to just resort to crushing pills or splitting them up or opening up the capsules and sprinkling them with food. But especially with medications that have quite low potent doses in them, this could have a serious effect if some of the medication is being lost or isn't being ingested. And similarly, many pills are designed with a protective coating on the outside in order to withstand the effect of the stomach and increase their absorption. Therefore, this may compromise how much is actually being absorbed if you're altering it before you ingest it. And number 8, if in doubt, ask. If something doesn't seem right, do bring it up because these things can unfortunately be missed. So if you're aware of something that might be off, it's really helpful for you to bring it up as well. And so I always finish with some helpful resources. So obviously your healthcare provider or pharmacist are probably the best people to go to first because they're a bit more familiar with your situation. Certain pharmacies do offer full medication reviews to look for any potential interactions there as well. So this is something you can look into if you're curious. The more I look at the HealthLink BC website, the more I really like it. So I really find that's a good resource to look at, where you can call 811 if you have questions as well. Health Gateway is a website where you can access all of the medications that you've been given, which can be helpful if you forget that list or you forget which medication you're on. You can also show your healthcare provider just by looking into Health Gateway. And a really good drug interaction checker that I found was drugs.com. It's the FDA website. I found you could just enter in the number of medications you're on and their names, and they'll bring up the potential interactions that can occur there, or you can just search up a medication on its own as well. And the one on WebMD was good as well. Okay, so this is our second last one in the series, and our last one is next weekend with Drew, and he's going to be talking about supplements. So we hope to see you there, and we really appreciate all your support throughout this time. And so, yeah, if you have any other questions, thank you for coming.
I have a question for you, if I may. What is the maximum strength of Ativan on a daily basis?
I do not know the answer to that question.
Fair enough. Thank you.
I think the best place that you could
the pharmacists might well have the answer.
Yeah, exactly. They're definitely going to be a lot more familiar, or you can just Google are you asking the maximum dose of Ativan?
Yes, that should not be exceeded. That's correct.
Yeah, if you just look up maximum dose of Ativan on Google, that should bring it up as well.
That was a beautiful presentation, by the way. Thank you very much.
Thank you. So I'll look in the chat. So why was it depends? So essentially the reason why I said it depends is that it can be true. So the prescription medications will be listed on Pharmanet most of the time, but there are medications that you may be on that may not be listed on there. That's why I said it depends. So it's always best if you have a full list of what you're on. I think hopefully that answers that question. Are there any other questions? I know it's a beautiful day, so I don't want to keep people too long. Okay, well, thank you all so much for coming. If you have any more questions, again, feel free to email us at uvicmms@gmail.com. And yeah, hopefully see you all next week.